Started, huh? Next page.
Ma'am, I'm not seeing the page.
No, others? Are others able to
It's
see
the
the
same.
page?
We are able to see, ma'am.
Are you on mobile?
Ma'am, it's
I think the third
yes,
skip
yes.
it to third slide, ma'am.
Shall I take the first? You want to start again?
It's okay, ma'am. Yes, ma'am, next.
Okay, shall I start?
Okay, ma'am.
Okay, start.
Hello, I am Dr. Suja, one of the doctors in the antenatal clinic today. May I confirm your name and age?
Yeah, I'm Julie and I'm 30-year-old doctor.
How may I call you?
Julie is fine.
Okay, Julie, from the notes, I understood that you are here to discuss the ultrasound reports with me. Is that right?
Yeah.
Okay, Julie, since we have met for the first time, I would like to ask you some more questions so that we can reach a safe and mutually agreeable plan for you. How does that sound?
Oh, that sounds fantastic.
Okay. Okay, Julie, can you tell me more about this pregnancy?
Doctor, actually, this is my planned pregnancy. We were planning to get pregnant. I'm pregnant, and now I'm 32 weeks into my pregnancy. So far as everything is normal, but I don't know why the midwife say that some concerns with baby, so she decided to do this ultrasonography.
Okay, Julia, I understand your concern. I'll soon will be discussing the scan reports with you. Was there any history of any bleeding or excessive vomiting in the first 3 months?
No.
Okay, and everything was all the down screening, everything was normal, right?
Yes.
And what about your anomaly scan? Was
Yeah, it was
was
also
that also
normal. Yeah.
okay? Are you on any drugs right now?
Yeah, I'm on
Any
a
medicines?
supplementation. Yeah, I'm on supplementation.
Okay. Are you taking aspirin?
Oh, I don't know. They were about to start me, but then they missed it. I don't know why. And even I didn't emphasize more on that.
Okay, Julia, I'll look into that matter. And what was about the last scans? Were they normal?
Yes. The last scan was at 28 weeks. I think that was normal.
Okay, Julie. Okay, and are you having any history of any blood pressure for you?
No,
Everything's okay. And do you have any history of any headache or blurring of vision?
no,
Okay. Have you named your baby?
no, doctor.
Okay. Is the baby moving well?
Yeah, my baby is quite moving well.
Okay. Just confirming this is your first pregnancy, right?
Yes.
Okay. And how are your cycles? Were they regular?
Yeah, they're regular, and I'm corresponding by my cycles also.
Okay. And you're up to date with your cervical smears, right?
Yeah.
Okay. Any other medical conditions for which you are seeing your GP?
No, doctor, nothing. I'm fit and fine. In fact, I do good amount of exercise during my pregnancy. I do take care of
Oh, that is
myself.
very. Oh, that is very good to hear, Julie. Any history of any surgeries for you?
No,
Any family history of concern?
no,
Any drug allergy?
no.
Okay. Just asking some personal questions. Do you smoke?
Oh, yeah, that is some problem with me actually. Although I have cut it down from 20 to 25, and now I'm sick taking 5 to 6 cigarettes a day, not more than that.
Okay. Are you planning to quit smoking?
Yeah, it's a slow procedure. I'm taking time to quit it. Yeah, I'm in touch with the services.
Okay, just to tell Julie that smoking can be deleterious to you as well as the baby. It can cause reduced size in your baby as well. So, if you would like me to connect you to the NHS smoking stop smoking services, I'll offer you that. Is that all
Oh,
right?
okay.
What about alcohol?
No,
Okay. Any recreational drugs?
no.
Okay. What do you do for a living, Julie?
I'm a means I'm an officer who works in some relationship purpose.
Okay. What is your weight to height ratio?
It's normal.
Uh, okay. What's your blood group?
A positive.
Uh, how is your support at home?
Yeah, I had married to my husband and we are together since last 2 years, so things are pretty normal.
Okay, that's good to hear. And how are you feeling recently?
I'm fine, doctor.
Okay. Thank you, Julie. Thank you for all the information. May I examine you in the presence of a chaperone? I would also like to take your blood pressure, your heart rate, the fetal heartbeat, and also I would like to check your urine for some proteins, and also I would like to check your tummy to see the baby size. Is that okay?
Okay.
Is there anyone with you, Julie? As I have a lot of information to share. Do you want anyone to be with you?
It's okay, doctor. You can just continue.
Okay, Julie. So your reports are with me, and I've confirmed the NHS number and the name. Uh, and you can see this uh, figures, Julie, here. Uh, and the last scan, as well as the scan we have today, there is a lag between the pregnancy date and the size of the baby. The size at what we are expecting, the baby hasn't reached at this point of time. This we call it as fetal growth restriction. Are you with me? Have you heard about this?
Okay.
Okay. Now in this picture, you can see there are three lines in the scan, and we usually measure the head size, the abdominal size, the tummy size of the baby. And in this tummy size baby, usually all should fall between these three lines. When the growth is less, the parameter go towards the lower line, as you can see in the second picture, and the baby is not up to the mark. Am I clear so far?
Okay. So now what, doctor? Why the baby is not growing, doctor? I'm worried about that. And does it has to do
This
something with aspirin, the tablet?
No, Julie, I can understand your concern. This can be due to a lot of reasons, not exactly maybe because of the aspirin. And we also don't start for aspirin for everyone. But in your case, exact reason we don't know. Most it can be due to maternal factors, the mother factors like not taking appropriate diet, smoking, the weight of the mother, the placental function, that is the afterbirth, if it is not properly working, the blood supply to the baby, all can be reasons for any infections to the baby, all can be reasons for the uh, less growth for the baby. Am I clear so far?
Okay.
So this can cause some problems in the baby, that is it can cause some breathing difficulties after delivery, some feeding difficulties for the baby, and can some minerals in your baby's blood can be low after the birth. And since there is not enough fat, there can be less temperature also for the baby, and it might be a little difficult for feeding as well. Am I
Okay.
clear so far?
Okay.
Okay, so you'll be managed by a team of doctors that will include my consultant, the fetal medicine doctor, the specialized midwife, and the baby doctor. By from now, you will be booked under the consultant-led unit, and I might also refer you to the fetal medicine specialists. They will monitor you with serial scans to see whether all the parameters is normal, and they will also will be looking your baby's weight. A specialized scan called Doppler can be done to see if the blood supply to the baby is also normal, and the water around the baby is also will be checked. And if any abnormality will be seen, and they will be intervening at that point of time. Are you with me, Julie?
Okay.
Okay, and depending on the scan, if there is any abnormality in the blood supply, we might have to intervene early. Otherwise, if everything is going fine, by around 36 weeks, we'll decide on the mode of delivery. And this will again depend on the scan. If the Dopplers, everything is normal, we will always aim for a vaginal delivery for you. Oh,
Okay.
is that okay? Okay.
Yeah, doctor.
And but if there is any distress for the baby, or the baby is not in the correct position, or if there is any Doppler abnormality, or the growth is less, we might have to do a cesarean section as well. Okay,
Okay.
Julie?
Okay.
And I'm sorry to say, but in rare cases, there can be a sudden death of the baby inside the womb also.
My God, you're scaring me,
Okay.
doctor.
Oh, I don't no, wanted to scare you, but I would like to be open and honest with you, Julie. But that is very rare. That is why we are trying to monitor you frequently.
Okay.
Okay, Julie. Okay. So during labor also, we'll be continuously monitoring the baby's heartbeat in a paper, and we'll try for a delivery also. And during delivery also, the baby doctor will be present, and after delivery, the baby will be checked by the baby doctor also.
Okay.
Okay.
Yeah.
And I would like to tell you that some lifestyle modification would be good for you, like reducing your smoking, as well as your weight to height ratio is on the slightly on the higher side. And I can offer you a dietitian and exercise specialist, so that in the next pregnancy we can reduce the risk. Is
Okay.
that okay, Julie?
Yeah, thank you.
Okay. I can fix an appointment with the consultant. I can give you some written information and connect you to the support groups. And I would also like you to check your fetal movements at times, and you might need frequent follow up as well.
Okay,
Is
thank you,
that
doctor.
okay, Julie?
Yeah.
Okay, thank you.
Okay, very well attempted.
Thank you,
Only
ma'am.
thing, 2 minute overshooted. The time has overshooted by 2 minutes.
Okay, ma'am.
Okay. Few
Okay.
points. Here are only few points which I just wanted to explain you. Uh, this very nicely you had started on introduction, then you had started eliciting the history. You are very much targeted to the risk factor for that SGA. I don't know why you asked me about emotional history. No need. Smear history, no need. Okay. Aspirin, very
Okay.
good. Blood group, not needed. Do you think here anywhere an NHS name and NHS number has been mentioned? No, nowhere the NHS number has not been
No.
mentioned. Yeah, so avoid those things. Okay, so I am having your reports or your growth charts, not even growth charts only. Okay, so ultrasonographic growth charts, not the complete report
Okay.
also. Oh, you that is situational awareness. What you have to acknowledge. Huh? Then it
Okay.
is fetal growth restriction. Do you think it is fetal growth restriction?
Ma'am, it is on the 10th centile, I think. If the Doppler
It
is
is
normal, then
SG.
it is
Yeah.
SGA.
So
SGA.
just tell her that if the blood flows are normal, then this is just a small for gestational age babies. Okay. So these are the babies which fall on this lower 10th percentile of the graph. So you have to just explain graph very simple way. So these are the babies who are actually 0 to 100 babies if we plot and see. So the 90% of the babies or the 80% of the babies, the upper 10th and the lower 10th, we will just remove. So that 80% of the babies will be falling into this in between two lines, and the babies whose point will be falling below this are less than 10 percentile. And that in this case, your baby is also falling. AC is falling. Okay. So the baby is not growing the way it should have been. We call it as a small for gestational age baby, SGA. And when it will be FGR, when the baby's blood flows will be also compromised, then it will be FGR. Yes.
Yes, ma'am.
Okay.
Less than third
We,
centile also.
yeah, less than third centile, but here it is not less than third centile. It is just a 10th centile, no, dear?
Yes,
Do
ma'am.
you think it is just on the ACs also, not on the so abdominal circumference where the baby has been on this lower side? Okay.
Okay.
Hmm? So that is these are only few points where I just wanted to intervene. Otherwise, everything is normal. In very non-directional way, you had counseled me regarding the smoking. You could have offered me any nicotine replacement therapy would you like to discuss. So they could have offered you. Okay. So that is
Okay.
also one good point which you could have added. Okay. So my answer key also includes whatever you had said. So worried about the growth of the baby. That is my concern. Aim setting agenda very appropriately. Uh, how is pregnancy corresponding from last menstrual period? Very nicely you asked me bleeding, nausea, vomiting. Then risk factor for IUGR you wanted to rule out by asking few questions. Okay, you asked here few questions. That is medical conditions you had asked me. What are the risk factors for IUGR? Can anybody enumerate? This is the first pregnancy. Okay, so smoking, drug abuse, uh, nausea, bleeding in the first trimester, severe nausea, vomiting, or pregnancy, uh, nutritional deficiencies. So all these are the risk factor for SGA babies. Okay, SGA babies or LGA babies. Sorry, SGA babies or FGR babies. So you can ask at least 2 3 points, so the examiner will know that, oh yeah, she has that points in her mind. So I could make it out that okay, so you wanted to rule out that. Medical surgical smoking history is important. You have to appreciate because she is cutting down, but yes, complete quitting is always important to minimize the risk completely, totally stop the risk. Okay, alcohol, occupation, drugs, support, domestic violence, just because it's a SG, I have included that, and BMI. And you had offered me examination to check my blood pressure and urine also. It has been mentioned in the answer key, so even I had mentioned it in the. So this is since this is a SGA babies. Okay, since this will be considered as a high risk pregnancy because the babies are getting affected, baby's growth is being affected, and there is a history of smoking. So this is basically a SGA pregnancy. So have you heard about this? Check the explain the growth charts to the patient. So very nicely you can just explain. So these are the 100 babies which we have plotted on this graph. The 10 out of these 100 babies, the 10 babies will fall below this lower line. That will be my explanation. So the the 10 babies will be fall below this lower line and they are labeled as SGA. Simple things, you just need to make it little simple. So either it will be your baby size, baby's weight, or baby's abdominal circumference. So that means it is lowest of the 10% of those babies. So smallest 10 out of every 100 babies, this will be SGA. So what are the implications? On mother, no implications. But for, or max to max, the mother needs to be extra careful. She needs to keep a kick count, more frequent following she will be having, okay? And more risk of intervention. For baby, the risk will be like short-term implications will be less oxygen supply to the baby, less nutritional supply to the baby will be growth restricted, the baby may require an ICU admission. Yeah, there is a small risk of baby dying in the womb. And sometimes serious illnesses and dying shortly after birth is also a problem. Feeding problems, feeding problems and difficulty in taking breaths, okay, so that respiratory problems will also be a problem in these cases. So that I think I had mentioned somewhere else, but here I had not mentioned, okay. So respiratory distress and that gastrointestinal problems also can be there with this preterm babies, okay. If this SJ babies. So reason or causes. So there are many causes. Sometimes it's just a constitutional. The baby is like that only because it depends upon multiple factors. The build of mother, father, the ethnicity, the number of baby you had. Babies tend to be heavier with each pregnancy. Sex of the baby, male tend to be heavy. So these are just a constitutional thing. Nothing wrong with the baby. Hmm? But some in few cases the placenta will not be working the way it should have been because of some medical problems like high blood pressure, which is called as preeclampsia, smoking, certain drugs, anemia. So these are the placental related factors where the baby is not getting the adequate nutrition and oxygen, and that's the reason baby is growing slow. Some infections are prone to cause baby's growth slow, and some genetic problems. So these are the problems where the baby is expected to be grow less. So what next? Flow. What next? So now what you are going to do? Yes, the next management you had very nicely explained me that you are going to monitor in the fetal medicine expert unit through blood flow. By serial ultrasonography. If everything is problem and if everything is normal, we are not worried about the baby. We will just keep a watch on the baby's movement and we'll wait till labor starts. If everything is normal. If there are changes in the blood flow, not concerning, we will see to it, you will be delivered in the consultant-led unit. There will be continuous fetal heart rate monitoring. The baby doctor and the neonatologist, baby doctor or the neonatologist and NSU will backup will be confirmed. Okay. But we will try to deliver you at what gestation? Okay. At what gestation? By 37 weeks of gestation. So here we will wait not more than 37 weeks. Okay, so here we will not wait more than 37, not beyond 37 weeks. But if at all there will be certain concerning changes like that reduced or absent flow to the baby, then in that case we may have to consider delivering early by cesarean section with the cover of steroid and magnesium sulfate. So these are the options what you are having. So normal, we will wait. If abnormal but not concerning, 37 weeks. If reduced absent with steroid coverage, we will have to deliver. Meanwhile, we need to completely cut down on the smoking. If needed, we can offer you this nicotine replacement therapy as an alternative. So as of now, you just need to keep a watch on your baby's movement, referring to a fetal medicine expert. Once that has been done, we can discuss with my consultant along with your partner. So PIL of having baby small is very important because you have to take a name of specific PIL and anesthetist review because these patients might require interventions early or later. So anesthesia review for that and document her care. So this is a pathway which has been mentioned when it comes to high risk criteria pathway. Okay. Abnormal umbilical Doppler artery pathway, we all know how to monitor. If less than 32 weeks, DV Doppler will be done. DV Doppler will be normal. We can wait till along with CCTG, if DV Doppler and CCTG is normal, we can wait till steroid acts. Okay. and normal. So domain-wise scoring, good history that identifies the risk factor of small for the gestational age babies, including smoking. Comment about aspirin. Yeah, very nicely you had addressed that question, why it has not been started. Actually, it should have had been started in your case. I will look into the matter. Smoking, yes. No, aspirin, yes. Aspirin. The studies have shown that it prevents the babies growing small in few cases. Not always, not always, but in certain cases, yeah, it do reduces the risk of baby growing small and minimizes the risk of having increased blood pressure of pregnancy. So that also you can mention here. A certain by ultrasound scan was done. Review notes asked. So rather than reviewing notes, you had asked the history. So I will take it that way. Offered examination. So clear pass in information gathering. 2, 3 irrelevant question. Please try to avoid, but still it is okay. Communication with patient, plans for care. Okay, very structured way you had gone, and you had discussed the plan, how you are going to monitor my baby, and you had also mentioned about the DFKC, which is very important here. What is DFKC? Daily fetal kick count. Communication with consultant, community midwife, fetal medicine experts, even neonatologist can be considered here. Education on perceiving of fetal movements are very important, so that you had mentioned, but it has been mentioned after 10 minutes. So always ensure you will say somewhere early only, okay? Because nowadays this they are very much worried about that. They wanted to reduce their stillbirth rates. So they wanted to do all the measures to minimize that. So DFKC, nowadays they are encouraging patients to watch about, means have awareness about your baby's DFKC. Then other symptoms are preeclampsia. You could have avoided that history of headache and blurring of vision. You asked me when I told you now I am not having any high blood pressure during pregnancy. So you could have skipped that question, okay? Explore and address the issues that the patient is anxious about. Balance risk of preterm delivery. Consider steroids if the delivery is before 34 weeks. Associated neonatal complications, that is intrauterine complications of growth restriction. So that feeding and breathing complications if the baby is going to deliver early. Otherwise, NICU admissions and all those prolonged hospital stay, all those points you have to mention. Possible factors associated with SGS in this case, rationale for further scan and monitoring, decision on timing of the delivery and how to deliver, discuss the risk of the patient, risk to the fetus in utero and ex utero, demonstrate the understanding of RCOG. There is this new guideline. So please ensure that you will do this topic very well. Okay. So whenever there are new guidelines, they are very much fond of giving the new topics. And nowadays they are actually wanting to minimizes their stillbirth ratio. Okay. Any question anybody having? Shall I end?
Okay, ma'am. Yes.
Okay. So now the next task